Good morning, respected teachers. I am Dr. Pulkit, SR Cardiology. I am presenting today the second case. It is robotic PCI with BIORESORBABLE scaffold. So this will be the outline of the case. 62-year-old female presented with angina at rest since last 10 days, which increased in severity since last first day. Patient has risk factors of diabetes mellitus since last 20 years and past history of rectal bleed present 3 years back, which required blood transfusion. And on clinical examination was unremarkable. Patient was stable, vitals was stable. On investigations, ECG was showing normal sinus rhythm with T-wave inversions in anterior leads V2 to V5. Of troponin levels were raised, and on 2D echogram, RWMA were present in left anterior descending territory. LVF was around 45 to 50%. So patient was diagnosed as a case of diabetes mellitus, coronary artery disease presenting with NST-ACS. Management: patient was given loading doses of aspirin and clopidogrel. Since patient was having rest angina, patient was taken for coronary angiogram. The access was right femoral. This is the coronary angiogram, which is showing this is the left main artery, which is normal. This is the LCX artery, which is non-dominant, and there is minor plaque in the mid. And this is the left anterior descending artery, which is showing a critical lesion in the mid part. This is the epicranial view, which is showing a critical stenosis in the left anterior descending artery in the mid part with TIMI2 flow. This is showing the critical 95% stenosis in the mid LED. This is the right coronary artery, which is normal with a minor plaque in the mid segment. So patient was diagnosed as a case of single vessel disease with LED disease in the mid part with 95% stenosis. Since the patient was having rest pain, the management strategy include PCI to LED. Since patient has a past history of bleeding per rectal 3 years back, patient was taken up to PCI for LED with BIORESORBABLE scaffold and for precise deployment of the stent under robotic assistance. A robotic PCI system enables control of coronary guide wires and intracoronary devices such as balloons and stents during PCI from a protected controlled cockpit. We use the CORE-PATH GRX system, which is composed of 2 subunits, a bedside unit, which consists of the articulated arm, the robotic drive, and a single-use cassette in which devices including wires, balloons, and stents are loaded, and a remote physician workspace, which is in the console and which is protected from the radiation and which consists of an interventional cockpit. This is the console, which this is the cockpit which is placed in the console away from the radiation, which is having multiple joysticks which help in the precise movement of the coronary wires, guides, and precise deployment of the stent. This is the cassette which we use in the robotic PCI, in which coronary wires are loaded and along with the guide, and which is controlled by controlled by the joysticks outside the in the console. And one operator also stands here near the patient. So first, a PTCA wire was taken and wiring of the left anterior descending artery was done. Then pre-dilatation with a 1.5 into 15 mm balloon was done of the mid LED was done, which resulted in an improved blood flow. A wire was also put in the diagonal artery to protect it, and it was kept in a provisional strategy. If suppose it gets stenosed during the procedure, a stent can be done. Next, pre-dilatation was done with a 2.5 into 15 mm of the mid LED. Then a stent was deployed in the mid LED. BIORESORBABLE stent was deployed of the size 2.75 into 32 mm. This is the stent which is placed, and this is the dilatation. Stent is being deployed in the mid LED with a precise deployment using the robotic assisted arm. After the stent placement, a shot was taken. There was no perforation, no dissection, and with a TIMI3 flow. A TIMI3 flow was achieved with a good end result. These are showing the markers of the stent at the ends. These are the platinum markers which help us to localize the stent. and then post dilatation was done with a 3 into 20 mm balloon, and we achieved a good end result with a TME3 flu after the successful deployment of the stent in the mid LAD. Treatment plan: patient has been advised a treatment plan of 12 months of DAPT followed by single antiplatelet therapy. Robotic PCI. It is a new technique which has come in the today's world, and it has potential advantage for the patient, which includes increased precision and procedural accuracy, such as deployment of the bioabsorbable scaffolds. Initially, imaging was used to deploy these stents. Now we can use robotic PCI to have an increased precision and deployment of the stent. And there are multiple advantages for the operator, which includes reduced radiation exposure, because the primary operator is outside in the console, which there is no radiation hazard, and improved ergonomics. So the primary operator can sit in the console room and can sit and easily control the PCI wires and balloons and stents, and there is no need of any wearing of the lead, and which has led to reduced orthopedic problems. Limitations: this robotic PCI hasn't been tried in thrombus-laden coronaries and tortuous vessel, and it cannot be used now with atherosclerotic devices like rotablation and in unprotected left main lesions and bifurcation lesions. So the PCI was done, the coronary intervention was done with balloon angioplasty, then came the bare metal stent, then came the drug-eluting stent, then came the bioabsorbable vascular scaffold, first generation. Now is the next generation with a thinner stud size bioresorbable scaffolds. These bioresorbable scaffolds are designed to reduce adverse effects related to permanent metallic stents by providing temporal mechanical support and subsequent complete resorption. They consist of biodegradable polymer PLLA backbone with a drug, example sirolimus. There is an absence of metallic caging that facilitates full restoration of the vasomotion of the arteries, induce luminal enlargement and plaque burden reduction, and mitigate lesion-related events compared with permanent metallic drug-eluting stents. They remove the potential reason of inflammation that may be responsible for late thrombosis or late stent restenosis. As the stents get dissolved, it restores the usual state of the artery with its original constriction and dilatation. Therefore, it also preserves all future options of reinterventions, and the stent dissolves over a period of 2 to 3 years. The outcome of BRS: the newer generation BRS at short and medium up to 3 years are encouraging, as studied in a MIRROR-1 trial, and safety and efficacy is proven up to 3 years. There is a 0% scaffold thrombosis both in Indian and international patients. However, its long-term safety tests remain unidentified. Limitations: the older generation, the scaffolds have thicker studs with large crossing profile. They cannot be used in tortuous vessel, and there was also a decreased tensile strength, which had led to greater risk of acute stress fracture. So the take-home message is that robotic PCI is safe and feasible after careful patient selection, and significantly increases precision and reduces radiation exposure to the operator. And use of bioresorbable scaffolds has potential advantages to improve patient outcomes in such as our patient. Thank you.